Uh, Hi, good evening. Can you all hear me? Just type yes if you can hear me, because I want to know whether we are audible to you. Let me check. Oh, yes. Wonderful. Thank you so much, Dr. Dima, Dr. Bhartaja, Dr. Nimala, Domita, Preeta, Dr. Emily, and so on. Thank you so much for confirming that we are audible. So today we have a very young, dynamic, and amazing speaker who is a very focused guy. As far as I know him, he's a very focused, very unidirectional. He knows what he has to do in life, and he's none other than Dr. M.S. Sarvana, who is a master in pediatric dentistry from College of Dental Sciences, CODS, India. He was the best ongoing student during his post-graduation with a university rank holder from Rajiv Gandhi University of Health Sciences, Bangalore. And then he went for different courses in laser from ILD, LEI, USSF, and then from the Manipal University also. And he has got fellowship awards from International Society of Dental Research, then Pedo Master Excellence Award and Fellow of International College of Dentists. He is a senior consultant in Chennai Apollo Hospital, and he is the first person to initiate laser assisted pediatric dentistry. We are proud of you, Dr. M.S. Sarvanakumar. And now I won't take much of time, because if I actually read his biography and CV, I think it needs half an hour. So I won't go into much detail, and let's hear from Dr. Sarvana. And thank you all attendees for joining us. And we have more than 360 in first 6 minutes of the webinar. And hopefully we will have more of attendees. And in the end, I'll keep you updated and how many people should join. And whatever the questions you have to write in the question box. And my request is, please write only one question each. Please write one question each, because it's difficult to handle so many questions, and then we do not do justice to our attendees. So it's better that you put one question each, and then I'll discuss in the end of the webinar one by one. I'll take up all the questions with Dr. Sarvanakumar. And thank you, Dr. Sarvana, for being here. And please, over to you now. We are ready to hear you. Thank you. Over to you.
Thank you, sir, for the good introduction. I'm very happy to be here. Thanks to SAPD for giving me this opportunity. And I was like a little worried how to give this presentation first, because talking laser basics and other things is not going to work out in this pandemic condition. So this is a saying which I got recently in a group, Feed and Buddies group, and I like this saying. And I pray God that all the people all over the world with good health, physically, mentally, emotionally, and economically. This is my disclosure. I'm using lasers for past many years, and the director of Torch Hill Indian Institute, trained many dentists, pediatric dentists. Today's like we're going to see how laser can be used in pediatric dentistry. It's a very good adjuvant tool, like the other tools. If you know the physics and the parameters properly, you can use the best way you can do that for the babies and children. This is my clinic in Chennai. Now I have a special clinic for only for tongue tie, where we work as a team with a lactation consultant, speech language pathologist, pediatrician, and social workers. We all think, when even like 9 years back, I was thinking laser means it's just a cut short. It is going to cut us through and through. But this will not happen. Even if you on your diode laser and if you lie down close to it for a day, it will not happen, because it is so much precise focus. Only when you touch it will cut. 1 watt laser can do an incision, but it is not going to cut to and through. All the lasers are electromagnetic radiations. As you see here, this is a visible range. Whatever I can see is only, whatever everyone can see is only 400 to 700 nanometer. Below that and above that, you will not be able to see. But the lasers, whatever we are using, is in the range of 810 nanometer, 940 nanometer, 980 nanometer, which is above 700. So the laser, what we are using, we can't see. That is the reason each laser will have one more pointer, which is 635 nanometer, which is in a milliwatt. It will be helpful for us to show the direction where the therapeutic laser is coming. So you should understand that each laser has a aiming beam, that is 635 nanometer, which shows where the therapeutic laser is coming. So this is the basic understanding of laser. And all the laser wavelengths what we are using, it's in the range of near infrared, mid infrared, and far infrared. Shorter the wavelength, it's very harmful. And all the lasers what we are using is non-ionizing radiation. It is not going to cause any mutation in the DNA. When we classify lasers, we classify them into two, that is soft laser and hot lasers, surgical lasers and non-surgical lasers. Non-surgical lasers are just like your torchlight or something like that, which you will use it for a photobiomodulation. The term LLT, low-level laser therapy, is not being used nowadays. We use a term called photobiomodulation. All the surgical lasers, we have diode. I have not used ND yet. I have seen it just in a practical session, but I have used carbon dioxide laser, 10,600 nanometer. Then I personally use diode laser, which is 940 nanometer, and then 810 nanometer, and I have a erbium laser, which is 2780 nanometer. So we just going to see the few applications and how we can use efficiently in this pandemic condition. If you see the range, this is the different lasers available for dental purpose. Aluminum gallium arsenic, that is in the range of 800 to 830 nanometer. This all is called diode laser. Diode comes under the classification of semiconductor. It is not a liquid laser, gaseous, or a solid laser. It comes under separate condition called semiconductors. And the erbium comes in the range of 2780, 2940 nanometer, and carbon dioxide in the range of 9300, 9600, and 10600. 10600 is used for soft tissue, whereas 9300 is come with a company called Solia, which is by my guru Kotlow. He has have a lot of things incorporated in that, and 9.6. That is 9600 is another laser which is coming out, Dendray. And are they safe? Are these lasers are safe for a pediatric use? Yes, I started using laser in 2010-11, and this guideline came in 2013, which shows that laser is a beneficial instrument in providing dental, restorative, and soft tissue procedure for infants, children, and adolescents. And the latest guideline is 2017, which shows how safely we can use laser for infants, children, and adolescents. What are the different procedures can be done with the laser? There is n number of procedures: soft tissue procedure and hard tissue procedures. You can do freenectomy, gingivectomy. You can do bleaching. You can do a crown. You can do a cavity preparation. Crown preparation you can't do. You can do a cavity preparation. You can sterilize the cavity. You can use photobiomodulation therapy. You can use a dye, that is called photodynamic therapy. In this pandemic condition, we have to follow the guidelines proposed by our national body. Either it might be SAPPD or IDA, and there are a lot of articles which has come out to show how important is we have to wear all this PPE and then work. So with this, I start. Laser safety is prime important, as always. Whenever I go for a lecture, I start with laser safety. Then only I'll go and deal with the other procedures. If you see the classification, all the lasers, whatever we use comes under 3B and 4. So there is the need for an eyewear. And there are special laser masks. I have not been used. I use N95 or PP, FFP2, some kind of mask like that whenever I work on a laser. But to be very frank, you will only get plumes when you overuse it. When you overheat it, you get lot of plumes. Otherwise, you can effectively, or you can just take out that using a high volume evacuation. So this is the thing what I have found in my experience. So to be very safe, it's better you use all normal procedures without any elective procedure. If you are using for a frenectomy or something like that, you can use your PPE and then proceed. Okay. And most of the studies which showed that plume contains virus is in the dermatology and gynecology, where they have used carbon dioxide laser. They used to burn a big lot tissue. It's not a small tissue how we used to use it for the gingivectomy or something like that. And the technique of use external cooling system, where you pour a saline on the area where you work, all this reduces the heat generation, and then you can reduce the amount of plume coming out or laser generated airborne particles. This is the plume which has come out in a carbon dioxide laser or a diode laser, and this is we are more worried about this. And American AAPD has given laser safety. We have to use a proper mask, high volume evacuation, and you can use your eye goggles properly. Wavelength specific eye goggles has to be used. I've gone through and saw the size of the coronavirus, and found that it is 0.1 micrometer, and the mask spot was been proposed like N95 and FFP2 or KN95 will filter even the particles at the range of 0.00 some. They have run a diesel generator, this generator, and then they have found it is more effective. There's only one study which shows there is no aerosol or no plume coming out from erbium YAG laser. I can feel how many of your faces are like this, showing different facial expression. Even when I thought I should give a webinar, I was thinking how I'm going to make a presentation at this situation so that it will be useful for all. We, instead of thinking out of the box, there is something we have to think to create a new box. This is what very well stated by my guru, who is Lawrence Kotlow. He is a person, because of him, I started thinking to learn lasers. When I started reading his articles in 2004 articles in 2005 or 6, when I was a postgraduate, I thought the laser has a very good beneficial effects in pediatric patients. So I started to do this. This is a very good article in 2009. He has done this. Whatever we see commonly, it's not normal always. Means we see a lot of tongue tie. Even 6-7 years before, even I was not focused. Your eye will see what a mind knows. Okay, so after knowing a lot of things, then I started seeing a lot of tongue ties. What are the ill effects of tongue tie? How it is going to affect the breastfeeding? How it is going to affect the suck, swallow, breathe reflex? How it is going to affect the speech of a child, articulation, chew and swallow, and sleep, and then all these things. So the maxillomandibular development, how the tongue should be in the correct position. So whatever you see commonly, it's not normal always. This is the definition for ankyloglossia. More than anatomical, this is a functional problem. Okay, so you have to diagnose it in a functional way. It is not a static problem, it is a dynamic problem. So the functional definition is, it's an embryological remnant of the tissue in the midline between the undersurface of the tongue and the floor of the mouth that restricts the normal tongue movement. You all should know what is a normal tongue movement. To do a breastfeeding, it's not only the tip of the tongue should move. it should be even the middle of the tongue should move to create a negative pressure so that the milk can be drawn from the breast into the mouth. So the functional definition is very important, and it has a genetic influence. It is seen more in boys rather than girls, and it is associated with midline defect syndromes. And it has, when the tongue is not lying high in the palate, it leads to high arch palate. So all these things are there due to tongue tie. I started seeing tongue tie. It's just like this. When I compare this, it's just like a small tissue. When you see, just like your iceberg, when you see inside, it's a big problem coming to you. How you're going to address this? By just only releasing the tethered oral tissue. That is the understanding we should have. Just by releasing it, it's not going to happen. There are a lot of other factors which is involved to get a proper prognosis. What are the symptoms when you see in a mom and in a baby when there is a tongue tie or a lip tie? You see a painful feeding, you see blistered nipples, you see blocked ducts, you see some kind of infection. In baby, they have a reflex because the tongue is not doing its work properly. They might take more air, and if there is a lip tie, there you can't close your lip properly. The air goes in, and the bloating of the stomach happens, and this leads to the gastro or esophageal reflux. So all these problems are there if there is a lip tie or a tongue tie. This is Kotlo's classification, where type 1 is the tip of the tongue is heart-shaped tongue, it's involved. Type 2 is the midline area under the tongue, creating hump or cupping of the tongue. And type 3 is distal to the midline area. And type 4 is one thing which most of us, or I was missing out earlier days, because the type 4 is one thing which I have found it's going to affect more. I have seen many cases in adults, and I ask them why you have not gone to release your tongue. They tell it's not affecting me in any way. But when I ask them the history, whether you sleep properly, whether you snore, why you have come here for a root canal treatment in the molars, and you have done root canal treatment for all the molars. The reason is the tongue is not able to clean the oral cavity like this. That is one of the reasons why you get a cavity. Disruption of the biofilm is very important. As I recently heard to the Dr. Meenakshi Kayer's presentation. So all these things leads to the dental caries. So this posterior tongue tie is one thing which is very, very important, which will affect the breastfeeding more than that of the tip of the tongue. And many of them I have seen a very good arched palate when the tip of the tongue is there. That is type 1, because they are able to compensate. They are able to compensate the tongue for the development of the palate. But when there is a submucosal posterior tongue tie, they were not able to compensate. So that leads to the high arch palate. There is a upper airway difficulty, and that leads to the sleep problem. And if you think of the lip tie, there is a lot of controversy. Earlier days, I used to mail Dr. Kotlo in our dental school. They tell us not to do a lip tie revision, lip tie release, because we wait for the alveolus to go grow and then come. But he has enlightened me with a lot of cases and research articles to show the high frenum attachment, labial frenum, might lead to the improper latch of the baby that leads to air leakage and air reflux. And this, there are a lot of things to learn. This might even lead to the dental caries in the anteriors, because it will pull the gingiva that will allow the debris to go in between the gingiva, and there is a biofilm formation which leads to a dental caries. And in older like children's, there might be a speech problem, And I have seen a lot of kids come and ask that they are not able to lick the ice cream. After that, one thing you should understand, it's not that we're going to treat all the tongue ties or lip ties who are coming. We should ask proper history, and then there is something you have to do. Since it is a muscle, you have to train the muscle before and after the procedure. Otherwise, you will not get the proper result, because your brain is, you have to uninstall the program and then reinstall. Otherwise, your brain will not take. That is one of the reasons why we do tongue tie release as early as possible. Fascia is one more thing what we should understand. It is a connective tissue covering the muscle and separating it from the internal organs. When this is tight, you can't do all your movements. Same way, when there is a tongue tie and there is a restricted fascia there, you can't do all the tongue movements. So you have to release the fascia in order to do the tongue movements. There are professionals called as body workers who help you out in releasing this with their procedure. Biomechanics of tongue. In this article is very well showed that how tongue plays a very important role in sleep apnea. So this is a model given by Dr. Dan in Australia, who tells that when the tongue tie is there in the infant, there is a breastfeeding difficulty, colic, mouth breathing. In children, the growth of the maxilla and mandible is affected. That might even prevent the crooked tooth and speech difficulty. In older age, you will see snoring, breathing difficulty, all these problems are there. With the due respect to all the mothers and all the women, they are all multi-talented. There's a lot of difficulties. I have two kids, one is 6 years old and one is 8 months old. I've seen my wife how much difficult it is to make them to breastfeed. There's a lot of problems associated. One problem might affect the breastfeeding, that is tongue tie. This is the latch before release and after release. Your mouth opening should be like 130 degrees. This is told by Mitchell. She is a body worker who was given a method called tummy time. And it is a severe pain. You don't know, it's very, very severe pain. The parents will really cry because of this pain. And I have been rewarded for a lot of times for doing this procedure. Upon 1 in 10 babies will have this tongue tie. This is given by NHS in UK. Is it a emergency procedure? Yes, rightly said by Kotlow. It is an emergency procedure. He has posted this in his Facebook during this March 22nd, and he tells it has to be done with proper precautions by your PPE and other things. So we also take it as an emergency procedure. Since it's a functional problem, you have to do a functional analysis. Like you have to put your finger inside and see the suck reflex, how much amount of force is given by the tongue, whether the tongue is doing its wave motion or not. Then you have to go for the diagnosis. It's not only many of the photographs, you might get many photographs with whether this is a tongue tie or not. You can't give a diagnosis only by seeing the photograph. This is not a static problem, it is a functional problem, dynamic problem. This is Alison Hasselberger's analysis assessment tool for to see whether it assists both structurally and functionally. This is what I was telling you, need a wave-like motion of the tongue. It's not only the tip of the tongue is moving, otherwise it will not happen. Breastfeeding will not happen. They might have some lacerating pain, the nipple get lacerated, they have more pain, and sometimes we ask the mother or most of these jobs I've stopped because earlier days there was not a team. They were very difficult to find a lactation consultants. I was like telling like 7 years before, but now we have a very good national body which gives you a lot of contacts for the national lactation consultants. So this gives a very severe pain if the middle of the tongue is tied. These are the photographs to show you how an infant's tongue tie looks. What are the different types of tongue tie, whether the tip is involved, whether it's a class 2 or a class 3. or I have some photographs even for posterior tongue tie. This is the optimal rest position of the tongue. This is after tongue tie release, and this is before tongue tie release. The middle part of the tongue has to move. So these are the photographs to show you. We do even tongue tie release in using general anesthesia, and sometimes we do it even in nitrous oxide. According to American National Standard Institute, with proper precautions, we can use lasers in general anesthesia and using nitrous oxide. And this is a baby, 6 weeks baby, who one of the first cases referred by a lactation consultant from US, and I got this baby, and with a lot of trust. See, you have to understand, they're going to give a baby, few days old baby to you, other than mother or father. That baby would have not gone to anyone else in that days. So you should understand the importance, and you should have the principle like it's our own baby. Okay, so you should have that feeling. This is not the position now I am following, because now I feel difficulty while working with the lasers. So I'm not telling them to hold them when the baby to do a tongue tie release or a lip tie release. Now I'm making them swaddle them, put it flat on the table with the accessories, and then stabilize them properly, and then start. This is a lip tie release and a tongue tie release. This is how it looks after one day, 24 hours to 48 hours. You have to tell them it's a normal type of healing. Even if you do it with a scissor or electrocartridge, it will be more bad. And you should know that this is the way how it looks. You have to explain them. This is the diamond shaped wound. This is sent by the mother. This is how you have to do the exercises. You have to you should not give more amount of force. If you give more amount of force, there will be more fibroblast formation, and that leads to something called as reattachment. This is how we generally give instructions before we start the procedure. We get the consent form, and we get all the history from the parents. And I can't take all the credit because it's a teamwork. It's a lactation consultant, body workers, speech language pathologist, pediatrician, occupational therapist, pediatric physiotherapist, and social workers. All of this work together. You should have a good frequency, like same frequency like a laser, and then we should work together. There are a lot of studies to quote, and this is one Indian study which told that phrenotomy seems to be a safe and effective procedure in infants with symptomatic ankylosing. And this is another study by a lactation journal of human lactation, which tells that phrenotomy has to be done to reduce the nipple pain, and phrenotomy for posterior ankylosing may improve breastfeeding and nipple pain. This is a conclusion, but the study tells that you have to do a phrenotomy procedure as early as possible for the best outcome of breastfeeding. This is one thing article which I quoted during the Indian Sleep Society conference, which was happened in Goa, where I was talking about the importance of tongue tie, and this article states how important is breastfeeding in the development of maxilla mandible rather than bottle feeding. And this is very important for me because it's not only the certificate we get, it's not only the attendance of the certificate, and it's a training. We go around the world to learn and improve the skill, because a lot of things are changing. So you have to know, you have to work with the lactation consultant internationally. This is Bridget Engel, who is the president of Australian orofacial myology. And I've just went around the world to see how Kotlo. I never thought I will meet him, but I met him in Chicago and in Toronto for the tongue tie conference. And this is Marjan Jones, E.L. Botcher. Most of us will be knowing. He has visited Delhi often, and he does a lot of scissor tongue tie release. And this is Alison Hasselbaker, and this is Mitchell, who I told it's a body worker who was given tummy time method. And Lisa is the one who has referred me a case during the initial days. And this is Lawrence Kotlow, and Peter Wittbrook is a PhD who has done carbon dioxide, manufactured carbon dioxide laser. And you all know all these people who are very big giants in orofacial myology. And this is Sarosh Zaki, who does a lot of tongue tie release using scissors and carbon dioxide laser. And he has a lot of study in Stanford University to tell the importance of tongue tie release, functional tongue tie release for sleep apnea. And this is Donnie, and Audrey Woon is again a very great person who has showed about the dome procedure and how to expand the maxilla for the obstructive sleep apnea problem, sleep issues. And this is Bobby Haria, and this is again Yale Botcher. I got a chance to go and watch one day in the world's best breastfeeding clinic, that is in Toronto International Breastfeeding Center. Jack Newman is a person, is a lactation consultant and a pediatrician who works there. These are the lactation consultants. I've learned that you know one thing, that I was there one day seeing how the breastfeeding goes, and I was able to do a lot of steps in assisting them in proper breastfeeding. So keep calm and do no harm. Doing no harm is very, very important. It's a lot of people who know me, who refer me, they know that all the case, whatever they refer, I don't go and do a tongue tie release or a lip tie release. Lip tie release is very, very less because it is a compensation because of a tongue tied tongue. So you have to know the importance of release, whether it's going to give benefits or not, and when to release. Timing of release is very, very important. Coming to the other procedures, what we do in pediatric dentistry. As I told you, laser safety is important. You should not get worried about your vital organs. If you are going to use your proper goggles, and it's, as I told you, it's a non-ionizing radiation, because the word radiation in laser alarms you, but it is a non-ionizing radiation. Tell, show, do technique has to be followed in order to make the child more comfortable, and this is what I do before the procedure. And most of the time the laser, what comes out is the aiming beam, and if I am going to press and work the pedal, it is going to be very, very minimal laser which is going to come. It is not going to cause any ablation, it is not going to cause any heat energy. So I just want to show them how they feel with the water and air coming. It is an erbium laser. And again, I'm telling you, the water and air coming from erbium laser, it's not that like that of the jets, like that of the aeroplane. The amount of velocity what it comes from the erbium laser is very, very less. So the I don't tell you no need to take precautions. You have to take proper precaution, but it is not going to splatter like that of an aeroter. It's going to be very, very less, and you can cut down the water, cut down the air, and then work if you want to reduce the splattering or laser generated airborne particles. Tell, show, do technique, and this is another case of tongue tie release where the child was having a speech problem. It was referred by a speech language pathologist, and it is released. When we use a laser, that's why in a practical session, I just try to teach all my participants, you should not force any equipment or any tool when we use in dentistry. When an aeroter or a scaler or even laser, don't force it to work. Let it allow it to work. You just keep it close contact, or if it's erbium, you can just no need to touch also. You keep it very near contact, and then you see the laser tissue, the tissue getting ablated. And this is a pre and post of photographs for your view. And anatomy, the underlying anatomy is very, very important, because when we do, there is a lot of anastomosis. That is the reason we have to be very careful. Once you do with scissor or something, there will be pooling of blood. You will not be able to see properly. So laser plays a very a very good tool, adjuvant tool for your tongue tie release. I've seen a lot of times deep lingual vein sometimes will be more superficial. So you can't take a chance and do a tongue tie release with a scissor. So I prefer laser, and I do learn the pre-conference course from E.L. Botcher about how to do a scissor release. Okay, and this is how it should not be done. If you do a tongue tie release so much with a lot of energy, this is going to affect the caruncle, this opening of the submandibular duct. This is what will happen. So this will cause plumes. This will cause laser generated particles. So you are using so much of energy to cut a tissue, and you have to know how to reduce it, how fast you should move, and all these things is very, very important. This is what we want people to learn before they touch the pediatric patient or an infant. I have done many frenectomies in adults. I've done a lot of cases, and then in children. Then I have come to the infants. So you should have a proper training. These are the few cases for you to show you how the laser disinfection can be done using a diode laser. There are a lot of articles supporting. There are few articles which which I've been quoting in the few after these slides. This you can sterilize the periapical region with a diode laser. This tooth has to go for a pulpectomy or extraction, but parents doesn't want to remove the tooth. So we have just taken a series of radiographs, and the main aim of pediatric dentistry is to keep the primary tooth in asymptomatic condition till the permanent tooth erupts. So we are trying to do that with a diode laser, and we found over the years the tooth exfoliated naturally, and this is to compare the adjacent tooth how it looks. These are the other few cases just to have the touch of how laser is used in pediatric dentistry. Even in the case of owl's tooth, the failure rate, what I've seen is very, very less. The replacement resorption or inflammatory resorption is very, very less when a laser assisted avulsion management is done. So these are the photographs to show you the whatever protocol, we have followed the same protocol, and then we use a laser. This is done. This is a study done in our department with the help of our HOD, Dr. Anjana ma'am. And in the study, we have shown that diode laser with sodium hydrochloride has a very good antibacterial effect, and the depth of penetration is more. But more than this, the erbium and diode together gives you more effect. This is a follow-up photographs of the owl's tooth, how it looks, and some minor procedures where they are very much the fearful child where they don't want any injection, and you can tell them it's a magic wand. You can show the laser, you can play with the laser, and then you just with the topical anesthesia you can do certain minor procedures to remove the overlaying soft tissue in which helps in guiding the eruption of the tooth. So all these are the minor procedures which you can do with the laser. The patient's cooperation is very much appreciated, and parents will be happy to see there is no bleeding, and you get a lot of referrals. This is a one tool in marketing. Pain assessment scale, most of the times we ask the child how he felt, whether he felt the warmth, whether he felt pricking. When I do a practical session with an erbium laser, I just put a marking in my hand and show how superficial it is, whereas a diode laser is a deep with a hot tip which gives more pain. So topical anesthesia is a must, or whenever there is a need to give a local anesthetic solution, you have to give a local anesthetic solution. Okay. These are the photographs to show some minor surgical procedure. It's a very good tool for the aphthous ulcer. It causes protein denaturation. The nerve endings are occluded and their symptom is reduced, but the healing takes same like that of the conventional. The time taken to heal is same like that of the conventional aphthous ulcer healing. In trauma, The diode laser has an effect called as photobiomodulation. It goes deep and it sensitizes the mitochondria of the cells to release the ATP in reactive oxygen species that gives nitric oxide, which is good for the healing, and that is one role which plays now even in COVID-19 pandemic. This is the photographs to show you how you can use a laser during the trauma to maintain the vitality and to improve the healing. Mucocil, you can use a soft tissue. See, the diode laser is a soft tissue laser which can be used only for a soft tissue. RPM laser is an all tissue laser. You can use it for soft tissue and hard tissue. But diode, you can't use it for a hard tissue. So this is a soft tissue procedure. You can use either erbium or a diode. This is the erbium laser. I am using it. If you have a diode, you can very well use it. Only thing is, I give some few tips. Cool that area before you work. You can keep the ice cube here below the lip and then cool that area when you work above, because diode laser is a hot tip. It is a hot tip. Okay, it is going to, you're going to initiate the tip, sharpen the tip, and then going to cut. Whereas erbium is not like that. It is going to work, ablating the tissue with the water. The chromophore of the erbium is water, so it is not going to create any kind of heat like that of the diode. This is a pre and post of photographs. Whether we can use a hard tissue laser for cavity preparation, all these things. I've done it before this COVID-19. If you are doing after this, you should take proper precaution, reduce the amount of water, air, so that there is no splatter coming up. So there's a lot of meta-analysis studies, Cochrane studies to show that role of laser irradiation in direct pulp capping procedures. And they have seen that more than 2/3 of the included studies showed that laser therapy was an adjuvant for direct pulp capping, was more effective in maintaining pulp vitality than conventional therapy alone. You can use an erbium laser to remove the soft tissue as well as the hard tissue. Selective ablation is one thing which is been quoted even AAPD guideline, which is one of the benefit of a laser. Selectively it will ablate because the DK contains more water. So the laser ablates decay dentin rather than it will not affect the normal dentin. So that is called selective ablation. Even in trauma, you can numb the pulp, analgesic effect, then you can start working. For this, you can use diode laser as well or erbium laser. But advantage of using an erbium laser is a superficial laser. It's very, very less traumatic to the child. There are a lot of studies to show how diode laser and carbon, how the topical fluoride uptake in primary tooth is improved when you laser it with the erbium laser or in carbon dioxide laser or a diode laser. The results showed that enamel surface irradiation by carbon dioxide and diode laser increase the fluoride uptake. These are the few things which you can do during this pandemic, where you're not going to touch the tissue. You're just going to show it in a defocus mode, that is a photobiomodulation mode. While photodynamic therapy is something you put a dye and then you show the laser. If you're not using a dye, then it's a photothermal effect. There are a lot of studies to show that bactericidal effect of diode laser on Streptococcus mutant after irradiation through different thickness of dentin. If it is less than 0.5 mm, it is going to heat the pulp. If it is like 1 mm, it's not going to cause any increase in temperature of the pulp more than 3 to 5 degrees. So it is very safe. You can use a diode laser to sterilize the cavity. If you want a photodynamic therapy, you can use indocyanine green or toluidine blue or methylene blue as a photosensitizer. These are the studies again to show you the effect of laser irradiation on fluoride uptake of SDF. They have compared 4 lasers, that is carbon dioxide, erbium yak, diode laser, and Nd:YAG, and they found that carbon dioxide and erbium laser irradiation improved the fluoride uptake. PBM, that is photobiomodulation therapy. According to FDA, it is been classified as non-significant risk device. What is the mechanism of PBM? It is going to act in the mitochondria, cytochrome C oxidase, and then it will release ATP, reactive oxygen species, and nitric oxide. In that, by this mechanism of action, it will help to photostimulation. If you want analgesic effect, you have to do photoinhibition. That is, your millijoules or a joule, the energy should be more than that of the stimulatory. That is what this graph shows. In this graph, the very important is when your joules per centimeter square, your power density, your irradiance is in the range of this, it will cause your photostimulatory effect. If it is more, it will cause photoinhibitory effect, which is needed for your analgesic effect, where it will act on the nerve membrane. It will reduce the nerve conduction. It will cause more depolarization. So all these things, the potential, the nerve stimulation is reduced. In that way, it gives a laser analgesic effect. This is one thing given by James Carroll, who's main person in Thor. That is a photobiomodulation using a LED and laser therapy. There is no published to date with PBM on COVID-19 patient, but PBM, that is photobiomodulation, can be used. The more relevant thing is it is anti-inflammatory effect. PBM is potent antioxidant. It seems to reduce the underlying cause of inflammatory cytokines. So the other effects of your COVID can be reduced using a photobiomodulation. Either it can be a LED or it can be a laser. This is the photographs which I got yesterday by Laura. She sent me this photograph to show how LED is being used for photobiomodulation. She has quoted, she has helped me with a lot of articles. I've read through it. It is a 58-page article, and I've seen there is some effects even on virus, encapsulated virus. Still now, there is no evidence to show it is going to directly improve the effect of COVID-19 patients. So these are the LED lights which can be used to improve the blood circulation, nerve stimulation. And one more thing, what we can utilize in this pandemic period is you can use a light activated disinfection. Okay, you can use a dye, which it can be a indocyanine green or toluidine blue or methylene blue, and then you can show the laser light for disinfection of the root canal or for the periodontal pocket or for sterilizing the caries. This is how the mechanism of action is like this. The type 1 reaction and type 2 reaction, it releases the singlet oxygen, and that is the way how it is going to affect the bacterial cell wall. Then I was searching whether how we'll get a dye in India. This is one thing I got it from net, where it is available in as indocyanine green is available as Oro green, Oro Labs in Madurai. So this is one thing I have found to get this dye and use. Normally, I use sodium hypochlorite or direct laser for the sterilization. And the efficacy of photodynamic and photothermal therapy on biofilm formation of Streptococcus mutant. This study has shown there is a very much improvement and reduction in the bactericidal effect and the count of the Streptococcus mutant when used with toluidine blue and indocyanine green. And this is another article to show you what is the effect of photodynamic antimicrobial chemotherapy on mono and multi-species karyogenic biofilm. The effect is very less because the concentration of the photosensitizer has to be improved in order to get the desired effect. Effect of photodynamic therapy with indocyanine green on Streptococcus mutant biofilm. This study states that concludes that photodynamic therapy using diode laser with indocyanine green may be suggested on the cavity disinfection after caries excavation as an alternative to conventional methods. So when you think whether if you have a laser in your clinic And if you think you can't use it during this pandemic, you can use it by this photodynamic biomodulation or photodynamic therapy to sterilize the root canal, to sterilize the periodontal pocket or your root canal, your cavity, so that you will get the desired effect. And if you ask me what are the benefits of laser, there are n number of benefits. This has been stated in guidelines in AAPD 2017. I just want to list this. There's a lot of, as I told you, selective ablation is one, which has been most oftenly quoted in a lot of articles. These are the benefits of using laser in pediatric dentistry. What is the limitation? Limitation is one wavelength will not be sufficient to work. So you need 2 wavelengths or 3 wavelengths. So the cost of purchase is very high when you compare. And one more thing is additional training. Laser use requires additional training, education for the various clinical application and types of laser. It's very, very important because there's a lot of changes happening. I update myself. Even now I am attending a lot of webinars to update myself about blue lasers, about 9.6 carbon dioxide laser, 9.3 carbon dioxide laser. There are a lot of things getting updated. This is one thing I often feel, because working with people who don't understand the importance of the tongue movements, it's very difficult. Earlier days, I felt very difficult to form a foundation in Chennai, going around to a pediatrician, to lactation consultants, very, very difficult to get them and go and convince them, or it's not like that, make them understand. And now I'm getting referrals, but still I have a lot of problems, which I can tell you that the real understanding is very important and teamwork is very important. When you get a proper team, you can help a lot breastfeeding that. Training is very important. We have training, we have a course to teach you all. We have dictative lectures, we have wet lab, we have a dry lab, we have hands-on on Gojo, we have patients work, and I'm thankful to Dr. Goswami ma'am for giving me an opportunity to do a first national tongue-tie pre-conference course and first national tongue-tie symposium. So you can learn a lot once you get certified and get in touch with the training. The training, what we do is with the help of the few international society and few international faculties or join us to help us in the course. I thank SAPPD for this great opportunity. I thank all the working body members, Dr. Gananda sir and all, Virendra sir, Rahul Hegde, a lot of Shivakumar sir, all the members I thank for this great opportunity. This course, what I told the course director is, this course, what I told the course director is, thank you.
Dr. Narendra, thank you so much for this webinar. It was a wonderful presentation. I got so many messages for the appreciation. And now I have a few questions to ask. We have one question from Hashita. She is doing a post-graduation in Mangalore, Mangalore. According to her, what exercises needs to be done for ankylosing, and any reference or book to refer?
Sir, I didn't get the question properly, sir.
Hello, can you hear me?
Sir, your voice is breaking, sir.
Can you hear me?
Sir, your voice is breaking, sir.
Is it?
Yes, sir.
You can't hear me?
Yes, sir. But it's breaking, sir. We can hear, but it's breaking, sir.
You can't hear me properly. Can anyone can they hear me?
No, sir.
So, can you maybe if I say now, can you? Or should I call you and give you a question? And give you a call. Hello. Hello. Separately, you're there on the net or online? Because there are a few questions I need to ask you. Okay, the first question is, like in case of ankylosing, what exercises need to be done, and any reference of the book to refer, you will say. Yeah, can you detail about it online? Can you be online? Yes, I can hear you.
Yes, sir. Sir, before release, sir, before okay. Before release, you have to do certain exercises. You have to do exercises the feeling. How the yes. And the book, and you have certain websites where they have some exercises. For example, most of the times I tell them to go and check Mouth Gym is one website where they give a lot of exercises. It is run by the speech language pathologist who's in Australia. She has tied up with us, and she helps in giving a lot of training exercise videos for the children and for the parents. So normally we tell them to do mainly suck reflex training to be done, and after tongue tie release, you have to continue the exercises for at least 3 weeks, 4 times a day. Is it okay, sir? Sir, can you hear me? Okay. Okay, sir. Okay, thank you. I wish others can hear me. So there are a lot of some exercises which has to be done before the tongue tie release and after the tongue tie release. And timing of release is very important. when a child comes after a few months, it's very difficult for them to train and learn the proper sucking. So weaning, mostly we tell 6 months exclusive breastfeeding is been advocated. So the other question is like functional analysis. There are different assessment tools we follow. One is Allison Hasselbecker tool. Yes, sir. Sir, you can hear me, no? Yes, I can see you, sir. I can see you, sir. I don't know whether there is a problem in mine. I don't know. Okay, so the assessment is
Yes, the problem is with the net. Can you hear me?
Hasselbecker assessment tool we use to see the structure, appearance item, assessment tool we use to see the structure, appearance item, and the exercises you can lot of I'm getting some echo. Okay. You have orofacial myology. You have orofacial, and I advise, I recommend doctor. Be able to few exercises. What I've done from him, few exercises. What I've done from him. There are a lot of online courses are there. Explain the protocol pre tongue tie release and post tongue tie release. I lost connected to webinar. Sir, what sir? You have to connect again, no? No, this is- And one more question is, when you work on an RPM, hello. Okay. When you work on erbium, whether if you are using for the soft tissue, whether it will harm the baby, definitely not. Erbium works with the chromophore water, and it is very superficial. They have compared different tools, and they have found erbium and carbon dioxide is best available tool for tongue tie release, more precise, and bleeding is one thing which most of us we feel with the erbium. But there are certain parameters, you can change the parameters and you can work without bleeding, and it is very minimally invasive rather than diode. Even though it is going to work on both the tissues, there is something called S mode and H mode, that is a hard tissue mode and soft tissue mode. Whereas the pulse duration is different. If you see for hard tissue mode, the pulse duration is 140 microseconds. If you see a soft mode, that is soft tissue mode, the pulse duration is 700 microseconds. Why the soft tissue 700 microseconds? Means to get the control of bleeding. So RPM laser, it is used for both soft tissue and hard tissue, but the parameters is just like switching off and on the different parameters. Books, there are a lot of textbooks available. You have a textbook by Larry Kotlow, you have a textbook by Richard Baxter, and you have a textbook by Atlas by Martin Kaplan, who is a mentor for me in American Board Laser Surgery. And you have a lot of textbooks are there available. You can make use of that. So any other things, you can contact Dr. Gyanandar or me, so that we'll be able to help you out in getting trained how effectively and efficiently you can use the lasers for infants and children. Websites, Bobby's website is one encyclopedia. Okay, you have A to Z all the things about the Bobby's Gaharia website. And Kotlow, as I told you, is an inspiration for me to enter into this field, laser. The reason why I want to learn laser is because how effectively, efficiently we can do a tongue tie release using a laser. That is the reason I started mastering laser, and then I started using it for adults, children, then come to infants. That's very, very important. Your learning curve is very important, because like you do re-endodontics, I'm doing a lot of tongue tie release who have done earlier, either it's a scissor release or a laser release by a ENT or a dentist. I'm doing a lot of things like that to get the proper functional release. So I don't want no baby should suffer because of inability, capability of an operator. So you should be more skilled enough to work on an infant. It's a moving thing, so you should be skilled enough to work on an infant so that you can give the best benefit. Next question. I once again thank SAPPD for SAAPD for this opportunity. Thank you. I wish you all healthy life. Thank you.